Good morning, everyone. So today we are going to discuss on stones. Because we are nearing the exam now, we will discuss it as 10-minute sessions, and we will discuss more on the ureteral stones in the first session and on the Staghorn stones in the second session. We have got a trainee who have agreed to record this. It is very useful in the sense that we can revise, and I have also tried to put some slides which gives evidence on the topics that we are going to discuss today. So shall we start now?
Yes, please.
Brilliant. So you are in the stone station. You have got a 28-year-old lady presenting with left loin pain. The call is from A&E. You are the on-call consultant. How are you going to approach this lady?
This has been referred as a urological emergency, so I'll go and attend to the patient myself, probably in A&E. On arrival, I will ensure that she's hemodynamically stable, adopting an ABCD approach, and I'll then take a focus history to confirm the site of the pain, duration, severity, radiating features, any associated symptoms such as fever, rigors, vomiting, any lower urinary tract symptoms or visible hematuria. I'll confirm her past medical and urological history, including that of previous stones and surgery. I'll ask about a family history of stones and also her occupation. I'll then perform a chaperone physical examination, primarily looking to elicit any abdominal or loin tenderness, and my clinical findings will then guide further investigations and management.
Great. So they have already done a CT scan. So which type of CT scan would you prefer if you suspect stone?
I'll prefer a non-contrast CT of the urinary tract.
Okay, well done. And are there any guidelines within what time would you arrange a CT scan if a patient is suspected to have renal colic?
So the NICE guidelines on renal and ureteric stones from 2018 recommend that it be performed within 24 hours, but there are also separate BAUS guidelines which recommend it be performed within 14 hours.
Brilliant. And the CT scan shows that there is a 6 millimeter stone in the left upper ureter with mild hydroureteral nephrosis. So how would you want to proceed further?
I'll arrange for further investigation. So these will be with the urine dipstick analysis to look for the presence of blood, leukocytes, and nitrites. I will arrange blood tests in the form of a full blood count, CRP, urea and electrolytes, and a serum calcium and uric acid, as well as a clotting screen. And I'll also ensure that the patient has had adequate analgesia administered, with my preferred choice being 100 milligram PR diclofenac suppository, provided that there are no contraindications. And it'll depend on the patient's current clinical status as to what the next exact management will be.
Okay. So the patient, when she presented, the pain was score 8. Her pain is better now. She says that it is a bit score 3 with painkillers. It shows only mild hydronephrosis. Her bloods are normal. What will be your thoughts here?
So my thoughts are that this patient could be managed conservatively. However, with her stone being in the size and location that it is, the likelihood of it passing out, according to figures from the MIMIC study, would be only 26%. I will offer her conservative management, and I will do so ensuring that she's discharged with analgesia in the form of PR diclofenac, but also offering her medical expulsive therapy in the form of tamsulosin, as this is recommended in the NICE guidelines for all stones up to 10 millimeters in diameter in the ureter.
Okay. So What is the role of medical expulsive therapy in upper ureteric stones?
So for upper ureteric stones, the role is, according to the NICE guidelines, it still has a role, given that it is a ureteric stone, so the location is not specified. But the evidence is pointing more towards lower ureteric stones in terms of effectiveness of medical expulsive therapy.
All right. Are there any RCTs to describe the medical expulsive therapy?
The one RCT was the SUSPEND trial, which looked randomized more than 1,000 participants with ureteric stones to receive either placebo, alpha blockers in the form of tamsulosin, or calcium channel blockers in the form of nifedipine. The primary outcome was the need for stone surgery at 28 days following diagnosis, and it's found no difference between all of the groups in terms of the rate of stone surgery. Although one of the limitations of the study was that 35% of stones in participants had distal ureteric stones, therefore they were more likely to pass spontaneously.
All right. What will be the indications to stop medical expulsive therapy and think of intervention?
So these indications would be if the patient has intractable pain, if they are readmitted with the same pain, if they have evidence of acute kidney injury despite MET, or if they have evidence of sepsis, although that would then be indications specifically for renal decompression and not stone removal.
Okay. And for a 6 millimeter upper ureteric stone, which has failed medical expulsive therapy, what would be your option?
So the first line treatment in the NICE guidelines is ESWL. So this would be my preferred option for this patient, and also provided that she's not pregnant.
Okay. So you have counseled the patient regarding the medical expulsive therapy. She agreed. And how do you plan to follow up when you start on a medical expulsive therapy regime?
So in terms of follow-up, I'll ensure that the patient is seen again in a dedicated stone clinic in no later than 4 weeks. I will look at the CT scout film to see if the stone is visible, and if it isn't, then I will request an abdominal x-ray before the patient is discharged from hospital to see if the stone is visible, and then they'll have a repeat x-ray performed when they are seen in clinic.
Okay, so you are seeing her back in the clinic in 4 weeks' time. Because her stone was it was not seen in the scout film. You arrange for a low dose CT scan, which shows that the stone is persisting. It has moved a couple of millimeters down, but it is still persisting. And there is no SWL list in the next 4 weeks available.
So I will inform her of the scan results, that the stone is persistent, and that I recommend surgical removal of the stone. Given the facilities available, I will counsel about undergoing a left ureteroscopy and laser lithotripsy of stone, plus or minus stent insertion.
Okay, and how will you counsel the patient for that?
I'll counsel her with the aid of a Bowes procedure-specific information leaflet, outlining the benefits of the procedure in removing the stone to prevent renal failure and infection, the alternative management of continued conservative management, but a low likelihood of stone passage. I'll explain to her how the procedure is performed with the aid of a camera, a telescope going into the ureter, and laser fibre to break up the stone. And I'll outline the risks of the procedure, with general ones including bleeding, infection, pain, and the anaesthetic risk, and specific complications such as bladder ureteric injury needing an open repair, ureteric stricture formation, failure to remove the stone, needing a repeat procedure, failure to access the stone, needing a stent insertion, stent symptoms such as hematuria, frequency and urgency, and also the failure to even insert the stent, needing an obstruction via a nephrostomy, and also that of stone recurrence.
Brilliant. Will you send the stone for analysis?
Sorry, will I send what?
Will you send the stone for analysis?
I will routinely send the stone for analysis to determine its biochemical composition, to guide as to whether the patient requires further metabolic evaluation or whether they need whether they need to be started on any specific medical therapy to prevent future stone recurrence.
So we'll stop there. So that is 10 minutes time. How was it for you?
I think this session's now with it timed. It's going to be different, and I progressed through it well. Don't know whether I got to the end of the scenario.
You got to the end of the. That was my last slide.
Okay.
Good. What all things do you think that needs to be improved?
I think just because in terms of the initial assessment, my go-to is to see the patient promptly. I suppose in real life, I would ask A&E if they've done any blood or investigations. So maybe I could have asked them for that. Forgot to mention the pregnancy tests as well, though. So I think for that, a young woman, I should have requested that. And then in terms of the indications for MET, I think the NICE guideline certainly states for any ureteric stone regardless of location, but the evidence is not there. It's more there in terms of distal ureteric stones. But I've managed this patient as per the guidelines.
Okay, yeah. So I completely agree with you. I mean, there are lots of positive points, no doubt about it, because I planned it like 10 minutes. And you got to the end of the slide. You will see that when you go through the YouTube recording.
Yeah.
So especially when one of the things that we have to look for is the age and the gender of the patient. So whenever a question is asked on stone, definitely the imaging comes. So if you focus on the age and gender, then definitely you will never forget to say about the pregnancy test.
Yeah.
And it is a good practice to write down when the examiner says about the initial clinical scenario, the keywords.
Yeah.
Regarding the medical expulsive therapy, the NICE guideline says that we can consider alpha blockers for adults, children, and young people with distal ureteric stones less than 10 millimeter.
Oh, distal. Okay.
Because the evidence was mostly for. I should say that with very carefully, because there are controversies in medical expulsive therapy. If we consider that one study with high quality, that was SUSPEND trial, Picard et al., published in Lancet 2015, and that was against. It concluded that tamsulosin and nifedipine will not. It will not improve the rates of further intervention at 4 weeks time.
Yeah.
They have a secondary analysis at 12 weeks as well, when they said that there is no difference in sub-analysis groups as well. So we know that there is a clear evidence, but however there are other studies, especially other RCTs, the largest one by Ian et al., around 3,000 patients, which concluded that medical expulsive therapy is good for stones more than 5 millimeter, especially in the distal ureter. So that is the reason that NICE guidelines in 2019 and also the EAU 2021 says that it's a strong recommendation to give alpha blockers as medical expulsive therapy for ureter stones more than 5 millimeter.
Yeah.
It is a bit controversial to say whether we can give medical expulsive therapy for upper ureteric stones, but as long as you know the evidence, if you say that the guidelines are like this, however, because this patient has the pain is controlled, not in AKI, and there is no signs of infection, and the evidence is equivocal, we can inform the patient regarding the medical expulsive therapy, and then tell about the side effects, the need for further intervention possible, and the possible failure rate according to the MIMIC study. So that is I think that is a way to come out in controversial situations, isn't it? Definitely, when you are performing like this, the examiners will tend to ask these questions.
Yeah.
So you can expect that if it is a upper ureteric stone.
Yeah.
I purposefully put as the upper ureteric stone because most of the time distal ureteric stones is straightforward.
Yeah.
When it comes only for the upper ureteric stones, then it is a bit controversial regarding the evidence.
Yes.
But overall, that was a really good session. Brilliant.
Thank you.
And any questions regarding?
No, I don't think so. I think that was more of a straightforward scenario that I suppose we've seen everyday practice.
Exactly.
But yeah, certainly in terms of the evidence, it's we need to just refine that a bit more.
Yeah, exactly. Shall we go to the next scenario?
Yes, please.
And in the exam, as you know, as soon as the bell rings, that's a exact stop there. So the examiners will not ask you more questions because we have to stick with the time in exams. So as soon as the bell rings, all the discussions will stop at that time.
Yes.
And then it will progress to the next scenario very quickly.
Yeah.
So even though we say that it is 10 minutes, in actual it is 20 minutes.
Yeah.
If you are sitting in stone, it is stone and infection. So for example, if you get this stone scenario, at 10 minutes the bell rings and then it will straight away go to the infection scenario.
Yep.
Okay. So we will go for the next session. I'm going to discuss the stone again this time.
Okay.
So you are sitting in the stone clinic, and this is a GP re-referral for a 54-year-old lady. She had a left flexible ureterorhinoscopy 8 years ago. She was discharged afterwards because her ultrasound scan showed that there is stone clearance. However, this time she presented to GP with left loin pain, and when the GP arranged for an ultrasound scan, it shows multiple stones in the left kidney, right kidney normal, nothing else in the ultrasound scan. So she's with her in your outpatients. How would you want to proceed from here?
So I'll see this patient in a dedicated stone clinic where on arrival they'll have urine dipstick analysis performed. I'll take a focus history asking about the duration and location of the pain, severity, any irradiating features and associated symptoms such as fever, rigors or vomiting, and also any visible hematuria and whether she's seen any stones in the urine herself. I will confirm her past urological history as outlined in the GP letter and her surgery and her general fitness for any further surgery. I will inquire about a family history of renal stones and also inquire about her fluid intake in the intervening 8 years and also her current occupation. I'll then perform a chaperone physical examination, noting the BMI in clinic and looking to elicit any abdominal or loin tenderness. And I'll go on to arrange further investigations, and these will be in the form of baseline blood tests with urea electrolytes, serum calcium and uric acid, and also a non-contrast CT of the urinary tract to confirm the presence of the stones and the stone burden and to help planning for any potential surgery.
Okay, so sorry. So she is otherwise fit and well. She has got a BMI of 32. Medical history of hypercholesterolemia and type 2 diabetes, which is well controlled with tablets. No other surgeries except for the flexible ureterorhinoscopy that happened 8 years ago. And your non-contrast CT scan shows a complete Staghorn calculus in the left kidney with slight thinning of parenchyma.
Okay. So I will see this patient again in the clinic and on an urgent basis, and show her the scan results and explain the findings that she has a large stone within her kidney, and that kidney is showing evidence of some failure associated with the stone. I will recommend that she undergoes clearance of the stone and surgical removal in the form of a left-sided PCNL. However, before that, given the evidence of cortical thinning, I want to confirm whether the kidney has a good function, and I'll therefore request a DMSA urinogram. I will also request a CT urogram with contrast to help delineate the calyceal anatomy and to help with planning for surgery.
Okay, well done. And her DMSA shows that there is 38% relative function of the left kidney. And yeah, so anything else do you want in form of investigations?
So I'll also send off a midstream urine specimen for culture. I'd requested a CT urogram, and also further baseline blood tests in the form of 4 blood counts.
Okay, so her CT scan shows that it is a acceptable anatomy. Sorry, I couldn't upload the CT now. So how are you going to proceed from here?
I'll see the patient again in my clinic and counsel that her left kidney has good function, and therefore I'll counsel about undergoing a left percutaneous nephrolithotomy. I will do so using the aid of a Bowser procedure-specific information leaflet, outlining the benefits of the procedure in removing the stone to prevent long-term renal failure and sepsis, the alternative treatments with surveillance, CSWL, or repeat ureteroscopy, but the likely need for repeat procedures with these. And I'll outline how the procedure is performed under a general anaesthetic with a puncture into the kidney through the back in order to clear the stone, and the risks of the procedure. These include a risk of blood bleeding, needed transfusion, and rarely embolization or nephrectomy to stop the bleeding, risk of infection or sepsis, injury to the surrounding structures. In this case, it'll be spleen, bowel, or blood vessels needing major intervention, and also risk of pneumothorax. I'm expecting there's also a very small risk of needing ITU, HDU care if serious complications occur, and a very small risk of death as a result of these, and that there is still a small risk of needing a further procedure to clear any residual stones, and that she may end up with having a stent or nephrostomy inserted with their associated symptoms.
Okay. Because she is asymptomatic now and she has got some family commitments, she is asking you whether the surgery can be postponed for in years' time.
I'll advise her that it is best to proceed with surgery at this moment in time because of the longer term risk of renal deterioration within the kidney that contains a stone, as well as a risk of developing recurrent UTIs and sepsis.
Okay, what is the evidence of the complications of Staghorn calculus, long-term complications?
In terms of conservatively managed Staghorn calculi, there was a review done by Alsawi et al. Last year, which combined data from 10 papers on this subject, including well-known ones such as by Blandy, Teichman, and Deutsch. And this found that the rate of overall renal deterioration long-term was 24%, and that disease-specific mortality was 17%.
Okay, brilliant. And so she agreed to your advice. She had the procedure done, complete clearance in with the PCNL. What will be your follow-up option for her?
So I'll arrange to see this patient again at 6 months post-surgery with an repeat abdominal X-ray. I will also send the stone off for biochemical analysis because she has a history of recurrent stones, and therefore I want to determine if she needs further metabolic evaluation.
Okay, so what are the indications for metabolic stone evaluation?
According to the EAU guidelines, these include if the patient is young, if they've had recurrent stones, if they have a family history of stones, and also if they have a known underlying disease condition predisposing to stone formation.
Okay, and what are the stone evaluation that you do? I mean, what are the parameters that you look for in metabolic screening?
So the initial mandatory metabolic screening is measurement of serum calcium and uric acid, and the further screening is a 24-hour urine collection.
Okay, and how would you do 24-hour urine collection?
I'll ask the patient to complete 2 samples, providing 2 bottles, one with acid and one without acid. I will ask them to ask them on one day to discard the first voided morning urine sample, and then to, every time they void, to do so into that beaker, and to include the next morning's urine sample, voided sample.
Okay.
I provide the patient with the form and labels and ask them to provide it to the local hospital biochemistry pathology department.
Okay, so why we are using hydrochloric acid, the acid in one and not acid in another one? What's the reason for that?
So the bottle without acid is used to measure the pH volume and the calcium levels, whereas the one with acid is to measure the uric acid levels, citrate, and the so I can't remember the other constituents it measures in the non-acid bottle.
Okay, so your patient had this metabolic screening. It shows that there are no risk factors for her. Her stone analysis showed that it is calcium oxalate stone predominantly, and okay, we'll stop. Okay, so I have stopped the timing. How was it?
Yeah, I think again I'm looking at the scenario. I think I progressed well through it, so got to another aspect of it in terms of metabolic evaluation. I think I requested the appropriate investigations, probably requested an MSU as well, and was able to justify why she needed surgery. But I'll wait and see what your feedback suggests.
It went well. Sorry, for some reason my screen got stuck. I couldn't upload the CT because one of the things I really want to know is how you read the CT scan.
Yeah.
We'll do it in a different scenario. Sorry for that. But otherwise, it went well. I reached the end of the slide, and as you can imagine, the last one was I completed the slide. So the last question was just I made up one question. So it is a positive sign. It's really good. You reach the end of the scenario. One thing is regarding the systematic approach. So whenever, especially in a Staghorn calculus or a patient with complications, suppose if the patient is, sometimes the scenario will be the patient is on warfarin, things like that. It can become a bit more complicated. So we can give always an approach like we will discuss it in the stone MDT.
Yeah,
it is always a good practice, especially for Staghorn, because there is a risk of mortality associated with Staghorn. You don't always have to, but still, in an ideal world, we have to discuss these complicated cases, especially recurrent stones, in a stone MDT. So it's nice to bring the stone MDT. And second thing is the approach. So it's always better to give the approach as I will look for the patient factors, the kidney anatomy factors, and the stone factors. So that is the approach given in the Campbell as well. So in that way we can see what all risk factors are we facing when we are doing a complex clinical situation like this. So sometimes the anatomy will be really difficult, in which case if there is a renal colon, things like that.
Yeah.
So and there can be situations when there is when the examiners can provide a CT cut which shows a retrorenal colon. So especially these are the things that we have to look for. I had that slide for, unfortunately it was not uploading. It got stuck. Sorry for that. But I think so that's the only thing I have to say. Otherwise, it was a brilliant session.
Okay. In terms of the evidence as well, because I only found that paper the other day, and I know it's not a systematic review or meta-analysis, but it just seems to. I don't know if you know the one I'm talking about, but it's just pulled all the data, including from the classical studies about this topic.
Brilliant, because I was expecting that study, because initially everyone was talking about Blandy and Singh's paper, and Teichman et al. Paper, and there are two more. So there are 4 studies which say that it is not the conservative management of Staghorn calculus is not ideal, but we know that from Deutsch and Subramonian et al. Paper, it showed that it is not as bad as we thought previously. So the reason one says that it just combined all the papers, so it's always better to give the new evidence. And most of the recommendation and most of the evidence is in support to treat the Staghorn calculus, especially for this lady, 58-year-old. We cannot wait for 1 year, because that's definitely going to affect her kidney function. It has already shown signs of deterioration.
Yeah.
So I think that was a good approach, and then you nicely brought out the evidence and even the latest evidence. So brilliant. That was really good.